model ultrasound machine with the endometrial thickness measured at its thickest part in the longitudinal axis of the uterus, measured on day 14 of the cycle. In terms of the preparation of the PRP, our materials and methods were a standardized procedure where we had our own centrifuge. We withdrew 10 cc's of peripheral venous blood on the 8th or 9th day of the menstrual cycle into a syringe that already contained 2.5 milliliters of acid citrate A anticoagulant solution. We centrifuged at 1,200 RPM for 12 minutes, which yielded the red cells at the bottom, a buffy coat in the middle, and the pertinent plasma on top. We then separated the plasma on the buffy coat, centrifuged again at 3,300 RPM for 7 minutes to obtain the platelet-rich plasma. Then we withdrew 2 milliliters of the PRP and injected it by the hystroscope through the operative channel by an open pickup needle into the subendometrial layer. We also standardized the hystroscopy equipment we used because we believed that the endoscopic procedure was a major part of our diagnosis, treatment, and management. It consisted of a Karl Storz HD monitor, HC1 camera, a Storz light source, and a hemoendomat. We used the office sheet, which consists of a 2.9 millimeter lens, the 30-degree optic with the Bitoki inner and outer sheath, yielding a total diameter of 5 millimeters, which in the future could mean that we can perform this procedure as an outpatient office procedure with the patient having minimal to light anesthesia. In future, it won't be necessary for us to give them general anesthesia or spinal anesthesia. Our fluid pressure settings were set at 1 liter per minute flow rate and a pressure of 150 millimeters of mercury to start with. We may increase the fluid pressure to negotiate the cervix during the diagnostic part of the hystroscopy, and then we reduced the pressure to 120 millimeters of mercury before we injected the PRP, which was done by a Wallace open pickup needle, a 17 gauge inserted through the 5 French operative channel of the hystroscope. We penetrated the endometrium between superficial and basal layer to a standardized depth of 3 millimeters, which equates to 2 graduation markers on the needle, and we injected in 4 sites, anterior, posterior, and bilateral, to completely map out the endometrial fundal area. Our patients received doxycycline and metronidazole twice daily in the form of vibramycin and flagyl, 2 days preoperatively and for 5 days postoperatively, and we followed up the leukocytic count between a preoperative and 3 days postoperative. The cluster differentiation 16 and 56 were measured preoperatively and on days 15 and 30 postoperatively. Our ultrasounds were standardized on day 14 over 3 cycles to assess the improvements of the endometrial thickness serially. In terms of our results, the collected data was encoded and entered on an Excel sheet and analyzed using the statistical package for social sciences, with a p-value less than 0.05 considered as statistically significant. The mean age of our patients was 32.1 with a minimum age of 27 and a maximum age of 36. The mean gravidity of our patients was 1.27 with a minimum of 0 and a maximum of 6. Our parity was a mean of 0.63 with a minimum of 0 and a maximum of 3. Procedure findings. In over 55% of cases, we did not find any anomalies inside the uterus. It was absolutely normal. The most predominant finding we did see were grade 1 and grade 2 adhesions. Grade 1 meaning filmy adhesions that were cut by the fluid pressure, not needed to be dissected by an instrument. Grade 2 adhesions, which were denser adhesions that needed to be either cut by scissors or by the tip of the scope. Next most common was a partial uterine septum, which of course when we suspected that the cavity had a uterine septum configuration, we would confirm with an intraoperative ultrasound in order to distinguish whether this is a septum or is it an arcuate or a normal variant. We also had less commonly cases of retained products of conception, 1 case of a T-shaped uterus, and 1 case which was confirmed to be TV endometritis after a biopsy. Our improvements in endometrial thickness, this is the most important slide. Our endometrial thickness improved compared preoperatively with the first cycle of 2.3 millimeters with a confidence interval of 2.5 to 2.1, and this was statistically significant. In this when compared to the second cycle, there was a mean improvement of 1.17 millimeters, and in the third cycle, it was down to 0.38 millimeters. All of these are statistically significant. The most important of which was between the preoperative and the first cycle postoperative, which improved from a mean of 5.5 millimeters to a mean of 7.8 millimeters. In terms of the natural killer cells, preoperatively and after 15 days and 30 days, the results were not statistically significant between the preoperative and 15 days. They were statistically significant between preoperative and 30 days postoperative, and it was considered safe. So statistically significant, we did not entice an inflammatory response with an increase in the cluster differentiation. The total leukocytic count preoperative and 3 days postoperative was also statistically significant, showing no changes. It was a safe procedure with no significant increase in the total leukocytic count. This is an example of the PRP we collected using the centrifugation. This is after the 1,200 reps per minute for 12 minutes. This is the red cells, this is the buffy coat, and this is the plasma cell layer. We would then recentrifuge the plasma with the buffy coat to obtain the platelet-rich plasma. This is a still from one of our procedures where the bevel of the open pickup needle was directed away from the endometrium in order to penetrate very finely without injuring the endometrium, because bear in mind this is very thin endometrium, very fragile endometrium, and we would penetrate into a depth of 2 graduation markers or an equivalent of 3 millimeters to distinguish that we are between the superficial and basal layers of the endometrium and not penetrating into the myometrium. Here is an example of the procedure. This patient obviously had mild adhesions towards her fundus, and these were actually just dissected by the fluid pressure. So again, similar to a subdermal technique, we penetrate the endometrium to a depth of 2 graduation markers, and then we begin to inject. And we notice for this bulge, which means that the endometrium is flowing, that the PRP is flowing between the superficial and basal layers, ballooning the endometrium. And then we go to the posterior side, as you can see here, and we inject. Again, you see this bulge being created by injection of the PRP, and we standardize 2 milliliters as our total amount used. So PRP on the endometrial thickness, are we just improving the endometrium short term, or are we curing the disease of thin endometrium? Our work shows a mean increase in endometrial thickness of 2.3 millimeters with a standard deviation of 0.7 and a 95% confidence interval 2.1 to 2.5, which is statistically significant in the first cycle, which is amongst the highest comparable to the results of Tundal-Watkar without addition of any estradiol or any hormonal support. And all of our cases had just 1 application of PRP rather than 2. When compared to the average of 1 millimeter increase reported by Chang and Wang et al. In 2019, we contribute the value of our better results, or the thicker endometrium we attain, to the fact that our PRP was injected in the subendometrial layer rather than just being flushed into the cavity by an intrauterine insemination catheter. 48 out of our 51 patients showed an endometrial thickness greater than or equal to 7 millimeters after the hysteroscopic subendometrial PRP injection. The 3 patients that failed to improve to the 7 millimeter threshold we set forth as thin endometrium all started. 2 of them had 3.9 millimeter starting point, and 1 of them had a 4 millimeter starting point. And there was technical difficulty in accessing the subendometrial layer by the Wallace open pickup needle. We could visually see that there was extravasation of the PRP during the hysteroscopy due to the fragility and frailty of the endometrium. We could not inject it strictly subendometrium. Follow-up over the second and third cycles showed a decrease to 1.17 millimeters and then 0.38 millimeters. Our conclusion was the subendometrial PRP injection is useful in improving the endometrial thickness during the first cycle of its injection and can therefore be used in IVF patients with thin endometrium who have frozen embryos awaiting embryo transfer. The endometrial thickness is not consistently maintained over 3 cycles, and it is a safe procedure, not enticing an inflammatory response in patients. we recommend the subendometrial PRP injection for thin endometrium to be done in the same cycle of desired frozen embryo transfer in IVF patients, and larger studies, preferably multicentric randomized controlled trials, are needed to assess the values of the subendometrial PRP injection for patients with thin endometrium in terms of their pregnancy and live birth rate. Thank you very much.
الرسالة الجميلة دي واداني فرصة أشوف فضل شلتوت ما شفتوش بقالي سنين، وإن شاء الله بعد الغم نتقابل إن بيرسون. وطبعا بشكر المشرفين الأستاذ الدكتور إسماعيل أبو الفتوح والدكتور وليد جابر. As a matter of fact, it's a very nice thesis to read. يعني it's written very nicely. البروبلمز بتاعت الكتابه فيها قليله قوي، انما طبعا ما فيش حاجه في الدنيا كامله. ف